Hi, this is Kristen at UT Southwestern Medical Center. Thank you for joining us today for our Facebook Live chat with Dr. Celette Skinner. Dr. Skinner she's interim chair of the Department of Clinical Sciences here at UT Southwestern, as well as an expert in communications intended for disease prevention and health prevention. So we are happy that she's here with us today. As usual, don't forget to like and share the conversation. We want to spread this message as far and wide as possible, and ask your questions in the comment section. We will take as many as we can get to. And remember that while this is a health discussion, we can't answer, and Dr. Skinner cannot answer any specific medical questions. So we're going to keep this general, but we're going to go ahead and get started. So welcome, Dr. Skinner.
Thank you.
It's fun to have you here today. So a question to get us started. I know you focus on population health as well as trends and factors that increase cancer risk. Can you tell us in a broad sense, what does population health mean? What kind of research is that?
Well, in a broad sense, it's really kind of what the name implies. It's population health, so we focus on populations of people or big groups of people rather than individuals. So when you go to see your doctor focuses on you. Mm-hmm. Or maybe people in a clinic will focus on people with a certain kind of disease. But we study huge populations, hundreds, thousands of people, to be able to identify trends of what's happening across populations, so then we can get information to take back to individuals. And the methods for doing that, we use a lot of statistics, and there are a lot of ways to be able to extract information from big groups of people.
Fascinating. I know we have several long population health studies going on here.
Yes.
So what are some of the focus areas of your research within your department?
So thinking about cancer, we, in the population research program in the Cancer Center, we study what we call the whole continuum of cancer, starting with you don't have cancer. We want everybody to stay there, actually. Prevention, what's your risk, and then cancer control or cancer treatment if you're identified as having cancer, and then we hope everybody will progress to having had successful treatment, and then you become a cancer survivor. And we look at really from before cancer to after cancer and everything in between.
Okay, all right. So what are some of the differences between when you talk about early detection, prevention, and control of cancer? How does that work?
Well, again, prevention is our favorite, because that's, if we could prevent all cancers, nobody would ever have cancer, and that would be great. But there are two main kinds of research you need to do to be able to help prevent cancer. So you need to figure out what are risk factors associated with getting cancers, because if you don't understand anything about causes, then you can't do anything about prevention, but that's not enough. Then you have to move forward to what we call intervention research, and that's figuring out how to translate what you found in risk identification to actually make a difference in risk. So example, I think everybody can relate to this. We've known for a long time that tobacco use was associated with lung cancer, and then over the years we found it's associated with many kinds of cancer.
Right.
But just knowing that doesn't translate into lower cancer risk. People have to understand, they need help stopping smoking, and so you've got to translate. And that's true of a lot of different prevention parts. But cancer control is trying to, as much as we can, minimizing the effects of cancer once it happens.
Okay.
A really great way to do that, for some cancers there is effective screening, so you can find it early.
Okay.
So with lung cancer, with breast cancer, if you find it as early as possible, when it's still very small, then the treatment can be more effective. But also there are things to help make the treatment more effective, like if you're still smoking, if you stop smoking during treatment, then that can make the treatment more effective. So we try to find ways to help patients do that. We try to find ways to help get people into care, even if they don't have routine care. And then the other part of cancer control is trying to help people live very healthy lives once they become cancer survivors and no longer cancer patients.
Of course. Wow. Well, that was our first question from Anna. So thank you very much, Anna. It's a great question to get us started. I mean, you talked about a couple different areas of cancer. I mean, what are some of the types that you look at particularly?
Well, one of the types of cancer that's become particularly important since the change of the century. In the last 20 years, liver cancer has become much more common than it was before. Incidence of liver cancer, and incidence is, how many people are diagnosed with it every year, has doubled over the last 20 years, and particularly in Texas. And also the mortality rate, or the people dying from liver cancer, that's the fastest growing kind of tumor that's killing people. Doesn't kill as many people as some of the other big ones, but it's growing so fast. We feel like, it's a boulder chasing us down the tunnel, and we've got to figure out how to get a handle on this. So some of the research that has been done here at UT Southwestern has looked at, for example, risk factors, thinking about prevention. Okay. And in fact, Dr. Helen Hobbs' group several years ago found that if you have a particular genetic variation, that you're more likely to get cancer.
Okay.
And so that's important. It also turns out that if you are obese, you're more likely to get liver cancer, and obesity is on the rise. And that genetic variation actually just happens to be more common among people of Hispanic origin, and so that's a big part of our population in Texas. So we're paying attention to that. And liver cancer usually starts out as cirrhosis of the liver.
Yeah.
We heard about, I remember even when I was a child, I heard about cirrhosis of the liver, and that was usually people got cirrhosis if they drank too much. Now people are starting to get non-alcoholic cirrhosis, not because they drink too much, because they weigh too much.
Wow.
And their liver collects a lot of fat, and cirrhosis is just a fancy way of saying kind of scarring. Livers are supposed to be nice and soft, and they do their job, but as they scar, then they get tough, and they don't operate as well, and that's really what can be a precursor to cancer.
Interesting.
And people are starting to have that if they're obese, but they're not, big drinkers. So it's a whole new, very important risk factor. So another area then that we've been looking at in the population science program at UT Southwestern, this is led by Drs. Marrero and Singal, is trying to find a way to look among people who have cirrhosis and see which ones of them are probably going to progress to have liver cancer versus not. Because not everybody with cirrhosis gets cancer, not everybody with that genetic variation gets cancer, not everybody who drinks too much gets cancer. And being able to predict who's going to move forward to cancer or not, then through a kind of blood test and ultrasound, then can allow us to find those people early and start effective treatment. And so their chance of living and becoming liver cancer survivors is much higher than if it's found late.
Wow, that sounds fascinating. Well, you touched on something a minute ago, and this was a question that just came through from Cece. Yeah. She says, obesity is a challenge for many in our country, even for children. How does obesity play a role in cancer? You touched on it a little bit ago.
Cece, we know more about the fact that it does play a role than understanding exactly why. And we have basic scientists here who are looking at that in the laboratory, but the most kind of simple explanation I can give is that, you think of your body, and you have a skeleton, and you have internal organs, you have a lot that's going on, and your body was meant to carry a certain amount of weight. And if you completely overload what your body has to support by lots of extra weight, then that can have several implications. It can cause inflammation all over your body, and inflammation is related to cancer risk. If you are obese, you tend to exercise less and less and less. Lack of physical activity associated with cancer risk. So then all of a sudden you have another risk factor. And we're even finding that some new data show that even if you have obesity or overweight, maybe during adolescence, it's not going to make you have cancer when you're an adolescent, but maybe much later when you're an adult. That is a risk factor that will sort of come back to haunt you.
Wow.
And it's hard to lose weight. And we need to find ways to help people maintain a healthy body weight.
Yeah, we've mentioned that in several of the chats we've had with people across campus, the difficulty in losing weight, whether it's genetics or environmental, and it's definitely a challenge. So here's another question that came in before the chat, and It says, why is it important for someone to know their family history when it pertains to cancer prevention? Have you looked at that in the data?
Well, we have, and I know you had a chat with Dr. Ross recently, who answered lots of specific questions about genetics, which I won't go into, but just suffice it to say that if you've had a family history of a certain kind of cancer, that may mean that you are at increased risk yourself.
Mm-hmm. Okay.
My father had melanoma, so I know I need to be careful about sunscreen and being checked, and that's true with many other cancers. So it's good to know what kind of cancers in your family, and there are some kind of cancers that maybe normal, average risk people start screening, say for colon cancer at age 50. But if you had cancer in your family, and especially if it was diagnosed early, before age 50, you might want to start screening earlier. So it's important to know about that and talk to your doctor about that.
Okay. All right, so for more specific genetics, you want to refer back to the chat we did with Dr. Ross earlier this year. So getting back to kind of what we were talking about a minute ago, I've heard a lot about, and this was something that came in ahead of time, about biomarkers. What exactly is a biomarker? Can you talk a little bit about that?
Well, some scientific terms are really hard to understand. This one is a little bit easier for us because bio is biological specimens, so something that comes from your body, feces, urine, blood, something that you can take a sample. And then a marker is something that marks or shows something. So a biomarker looks at, say, blood.
Okay.
For liver cancer, for example, there's a certain kind of protein, AFP, that if you have that, your risk is increased. So they can do a blood test, they can look at that and see if you might have increased risk. So really, and so we do a lot of research to find out we need more biomarkers that we can use so we can distinguish who needs to be screened earlier, who's at higher risk, that kind of thing.
Okay, that's helpful. So
did that explain?
Yes, that did. That was a perfect description. So I want to let everybody know we've got about 15 minutes to go. We're halfway through. I want to thank everybody who's tuning in. I see all those numbers rising in terms of visitors. And we did get another question in, so keep those coming. We'll take as many as we can get. So, this is a different question. She says, we know it's important not to start smoking, but what if you're already a smoker and you're diagnosed with cancer? Does that affect your treatment and recovery? Have you been able to determine that?
It does, and I think that's very good news, because some people who've smoked and get cancer think, that's it. But the good news is it is never too late to quit. There is always a benefit in quitting.
Okay.
If you are a smoker and you get cancer and you need to have surgery, if you stop smoking before your surgery, your recovery will go better. If you need to have chemotherapy or some other kind of treatment, the therapy will work better if you stop smoking. After you get through your cancer experience, your risk for getting another cancer later will go down if you stop smoking. The good news is there is always a benefit from discontinuing use of tobacco.
Wow.
So it's never too late to benefit.
There you go.
So that's a positive spin on a risk factor.
Absolutely. No, that was a really great question. Thank you to those of you that asked it. So along those same lines, we've talked a lot about liver cancer and its kind of prevalence and growing prevalence across the nation, particularly here in Texas. I mean, are there thoughts on why that's happening? And is there anything that the people that are watching or that'll watch this later can do about it?
Well, I think we already talked about the big risk factors. Obesity is a growing risk factor, and then there are some infections that are risks for some kinds of cancers. And for liver cancer, it's hepatitis B and C.
Okay.
Increase your risk. So there is a vaccination for hepatitis B.
Okay.
It only works if you actually get the shot, of course. It's like screening. It only works if you're actually screened. For hepatitis C, there's not a good vaccination, but there is now good treatment. Fairly new good treatment. And so if you are in a risk group, if you, like I am, are a baby boomer, then when you see your doctor next time, you should probably get a blood test to see if you have hepatitis C, and then if you start treatment, then that can lower your risk. But there are some other very preventable cancers, and one of those that we study a lot here is colon cancer.
Okay.
And colon cancer is one of the big cancers, and it's really sad because it still kills about 50,000 people a year in the United States, even though it is so preventable. So colon cancer usually starts inside the colon as a little growth that's called a polyp. And those polyps usually start out being benign, or they can be what's called precancerous.
Okay.
That they're going to become cancer, but they haven't yet. So they can be found, they can be removed, and then the cancer risk is gone.
And they're typically removed during colonoscopies or other checkups like that.
Right. So screening for colon cancer can actually prevent it. Unlike screening for breast cancer can find it early, but you've already got it. So there are multiple ways to screen for colon cancer, but there are two main ways. They're both effective. Either one is fine, but they're really different. One is doing a stool test at home. We call that, it's a really long scientific name, but we call it FIT, using a FIT kit.
Okay.
And that's just a little card, and it's got instructions, and it tells you how to take, there's a little stick, and you take a very small piece of your bowel movement, and you put it on the card, and then you seal it up, and you mail it back to the U.S. mail to a laboratory where they do a test. And if there's any blood in it, they say this is an abnormal, and you need to come in now for a colonoscopy. But if there's not, then you're fine, and you don't need to do anything until the next year. And the next year, you need to do it again. And every time it's normal, you still need to do it again and again and again. A colonoscopy, you can just start with screening directly with the colonoscopy. That's completely different because that's taking a day off work and coming in, but it's a procedure that's done by usually by a doctor. They give you some medicine to make you sleep, and then while you're out, they take a scope. It's called the colonoscope because it's a scope that goes up your colon. And it's flexible, and you don't remember it later, but they can really look with a little camera, and if they see a polyp, they can take it out right there. And then they can send it to be tested, and if it's precancerous, then nothing to worry about. If it looks like it's a problem, then they may say, well, you need to come back maybe in another 3 or 5 years, but if everything's fine, you're good for a decade.
Perfect.
Either one of those is fine. And the data show they will reduce cancer death. But you have to do them when you're supposed to. If you do a FIT test, you have to do it every year. And you have to come back when you need another colonoscopy. So we have partnered with the Dallas County Health System, Parkland Health and Hospital
The research
system,
you've done on the FIT test.
And the research that we've done to you can have either test, and we wanted to know what is the best way to help patients get one of these tests.
Oh, absolutely. And
so we took a large group. This was headed by Dr. Amit Singhal in some of our research, for which I'm a PI. And we had 3 different groups of patients. There were 2,000 patients who we mailed those FIT kits. And there were 2,000 patients who we mailed an invitation that said, please come in and have a colonoscopy. And then we followed 2,000 other patients who had the usual care. They came in, and if they saw their doctor encouraged them. And so we said, which one of these is going to be most effective? We didn't know. And nobody had ever looked at that before. So it turns out if you got one of these mailed invitations, you were much more likely to have any kind of screening test than if you didn't.
Interesting.
Even though, we think the best thing would be a recommendation from a doctor, not everybody got that, or maybe they didn't come in that year. So that was very effective, and a lot of people did that FIT test one time. And it looked like that was going to be the best. But then we continued to follow them over 3 more years. And it turns out that a lot of people who had the FIT test didn't come back and do it, or didn't do it again the next year when they got the mailing, or the next year. And so we have some work to do there. And then a lot of people who were invited for colonoscopy, a lot of them came and got it, but a lot of them still didn't. So we need to figure out how to get people all the way through the screening process, from having a test the first time to doing it again when they need to. If there's an abnormal, to follow that up. To have surveillance. If a problem is found, to get all the way to treatment. because you hear people say screening saves lives. Screening by itself doesn't save lives. Screening produces a test result that, if acted on appropriately, can lead to saved lives. But in some reasons, we've looked at why people don't get from one point to the other, and some of that is because of system failures. You know, they fail to get the letter saying what the test showed, or somebody was supposed to schedule them or didn't, or sometimes it's patient-related factors, like they were supposed to come in for a test and they, for some reason, they weren't able to show up. It's lots of different factors, and we need to study them all.
So that was one of the questions that did come in beforehand. Was, do social factors play a role into that? I mean, are there things like food insecurity or, neighborhoods that impact, how often people follow up with screenings or any other type of procedure?
Well, yes, we're finding out more and more there are what we call social determinants of health. And where you live, some people say your zip code is almost as important or maybe more important than your genetic code. I'm not sure we know that, but where you live is really important. For example, it's important to eat a healthy diet.
Of course.
It's important to get lots of exercise. Plenty of exercise, I should say, maybe not lots. But what if you live someplace where you don't have access to vegetables? There's no grocery store. There's only a convenience store. That makes it really hard to eat well, and that increases your risk. What if you live someplace where there's no safe place to walk? Or what if you live someplace where there is a place to walk, but everybody else in your neighborhood, or nobody else in your neighborhood does that, or will go with you, for example? Or what if you have to travel a long distance to go to a clinic? Or, of course, there are probably environmental pollutants, too, that we're just beginning to understand. But this is another area where, in Dallas, the Parkland health system has been great in addressing some of these issues, because they have put community-based clinics all over Dallas County. And we partner with them to try to figure out how to help them get people screened and other behaviors that are going to lower their risk that they can do right in that community clinic. They don't have to come downtown. They don't have to come
to the
far
medical
away
district or
from where they live. But there are many factors that affect health, and we have some investigators led by Dr. Sandy Pruitt, who has funding from the Robert Wood Johnson Foundation. They have funded a number of grants around the country to create a culture of health.
Interesting.
And so our grant, looking at trying to promote healthy behaviors, is with Crossroad Community Services, which is one of just a wonderful organization in Dallas that has food banks and does nutritional education and other health education. And so we're trying to figure out how to go into communities where people are and help them engage in healthy behaviors, cancer screening, and so forth.
Wonderful. So with that, I mean, are there ways, now how do you find your participants? Are there ways that people can enroll to be a participant in one of your studies, or do you look mainly at data?
Both.
Okay.
And so we do have a community research registry, and I don't have the website address right now, but we will post it after. If you would like to be on a list to be contacted for studies, please do that. Yes,
we'll post that on the event page and in this discussion as well.
Right, and then if you receive care at one of our hospitals, then we often invite people to do that.
So I assume that the guidelines for enrollment will vary depending on what sort of study.
Oh, and that has given me a great segue. I know we don't have a lot of time, but there's another.
We'll run it out. But
there's another piece of research I'm so excited about that we've done in cancer, and that is who can be in clinical trials. Clinical trials. Oh.
Go ahead.
Clinical trials, if you have cancer, are the way that new drugs are tested. And it's a way to find out if a new compound works. And so back in the old days, most people who had cancer wound up dying of their cancer. And so if they got a second cancer, they were excluded from a clinical trial because everybody assumed that because they'd had the cancer before and they'd been sick and had treatment, they wouldn't do as well. And so that practice of excluding people just sort of lived longer than it should have, and it turned out to be discriminatory. Because we have so many people now who have cancer, and say had breast cancer, had successful treatment, 20 years later show up with a primary lung cancer, and we're being told, I'm sorry, you can't be in a clinical trial. So our researchers used existing data, and this is also led by Dr. Sandy Pruitt, to show what a huge number of people were being excluded, more than anybody realized. And also looked at data to show that the people with previous cancer didn't do worse. In fact, lots of them did better after that cancer. So it's important to be able to let them enroll in these new trials to see how these new drugs are going to operate with people who've already had cancer. And as a basis of that research, the clinical trial eligibility has been changed. And now patients can enroll in lung cancer trials, and we're working in 6 other kinds of cancers now to create some evidence to show whether they will be able to enroll in other trials.
That sounds like just
it's really
a seismic shift in terms of enrollment. That's fascinating. So we've got one more question. So we are running out of time. We're going to take this last question from Amy, and then we're going to wrap up. So this one says that I read consuming too much fat increases cancer. Does that tie into any of the studies that you've been involved with?
I'm not aware of any studies showing that consuming fat in and of itself is related to cancer. Being overweight or obese is related to cancer.
Okay, there you go. Well, we are out of time today. Thank you for that question, Amy. Thank you so much for your time, Dr. Skinner. It's been a wonderful conversation. Don't forget, it'll be visible here on our Facebook page, and it'll also be on our YouTube channel later this afternoon. That's UTSW Med. And we will make sure to put the links that we referenced in the chat on both pages so that hopefully you will consider signing up to be part of their registry track.
That'd be great.
In the meantime, have a great day, and thank you for joining us.